very, very close friend of mine and has been an investigator and a colleague on the XLPAD study for a very long time, along with many others who are joined today. It's my privilege to welcome him. He's a star in his own right, and he's currently the Director of Interventional Cardiology at the University of Oklahoma. He is credentialed to have performed multiple keynote studies, and most important amongst them, where a study that has never been done before is a large randomized study comparing ultrasound-guided access versus non-ultrasound-guided traditional access under fluoroscopy. I mention this particularly because that shows Dr. Mazen's passion about peripheral interventions, coronary interventions, safety of intervention, especially his dedication towards compiling a complication course that he has addressed many, many times before. He spoke about this at the Dallas Cardiovascular Innovations. He is speaking here on it. He has authored multiple papers on this subject and also is going to speak on this subject on bleeding and safety and peripheral complications at the SCAI upcoming conference in Las Vegas. With those, welcome, Dr. Abu-Fadel Mazen. Take it away, and I'll mute my line.
So thank you so much for the great introduction, for inviting me. I don't want to take a lot of time to start because I have some cases I want to share with you. So my only disclosure today, I'm really much better interventionist cardiologist than these videos are going to portray. And interestingly enough, whenever you invite somebody to do a talk, you always, the week before, you come with 1 or 2 new cases you can show. So just to talk briefly about the safety of peripheral arterial interventions. This paper from 2011 from JAG Cardiovascular Interventions, even though it says in the title it's about complications in the elderly, it is a very large registry from the Blue Cross Blue Shield of Michigan, database. And the total number of patients in this database is almost 7,000, so very huge number of patients. As you can see here, they divided them into people less than 70 years of age, 70 to 80, and the last column on the right is more than 80 years of age. You see most of the procedures are being done for claudications, less so in the elderly. Of course, the elderly will have more rest pain and limb salvage. And most of the procedures are FemPop in nature, and of course multi-vessel, and of course significantly more the older we are. It's nice where they showed us technical success, even though it's very good. Again, it decreases with age, mainly because not able to cross or wire and get a device where it needs to be. And this is a spectrum of complications you can see in these people, and mainly bleeding complications. And of course, this is all because of most of the time access site complications. Of course, I'll show you some complications of bleeding, not because of access site. And the other thing is contrast-induced nephropathy, which is also very big and much more dominant in the elderly population. So with this very brief introduction, Subhash wanted me really to concentrate on discussing cases which we can learn from. So hopefully these will be good cases for you guys. Feel free to ask, interrupt, or Subhash, feel free to ask any questions as well. Make this interactive. So this is a 60-year-old male, hypertension, hyperlipidemic, and a smoker. He has symptomatic bilateral carotid disease. He had a left internal carotid artery stenting from left common femoral artery access. Most of the time we use ultrasound guided access for difficult access here because we've really shown that it does decrease complications and decreases the amount of time to get access, as well as you'll be able to head the common femoral artery more likely, and then you can use closure devices. I personally like to close all my carotid cases so they can ambulate early to decrease the vagal tone. Anyway, after the procedure, after a per-close device, he had a pulseless left lower extremity. And this is the first video. Just want to confirm that you guys can see it okay.
Yes, we can. It's showing.
Okay, perfect. So this is the access site. You can see access site is good. The middle of the head of the femur, no issues with the access site. And then we brought him back to the cath lab because really he was symptomatic without a pulse at the access site. We got access from the contralateral side. This is a pigtail in the aorta, and you can see already the flow in the external iliac artery. I'll let it run here again. Very slow compared to the internal iliac artery and the artery on the right side. So we knew there was a problem probably at the access side. Taking a more selective picture at the access site, you can see that the perclose suture here sutured the artery almost perfectly. There was nothing going down, so this is like an acute limb ischemia. You can see very, very vague contrast right here below the head of the femur and the common femoral and the superficial femoral artery and the profunda, but really the problem is right at the access site. This was the first time I see this, to be honest with you, so I had to kind of come up with a plan on how to do this. This is a whisper wire and over the wire balloon just to give me some support. I knew an 035 wire or 1/8 wire would not go. We needed something to go within the suture of the perclose. And here we were trying just to wire down into the artery, and you can tell that our wire is not really in the artery. So we removed the wire back, and of course we had a small perforation, because if you can imagine, the artery is completely occluded like a candy wrapper in the middle, and the wire, you're trying to get it inside the suture of the perclose. Well, probably we put a little bit more pressure on the site where it's sutured and then we perforated. Now, the nice thing is we can see it, we can hold pressure there. Perforation it's only a wire perforation, so it should not be a big deal. And you can see here we were trying to wire again as we were holding pressure, and we were successful in bringing the wire down to the superficial femoral artery. So now that we had a wire around this, through this, our options were either we try to balloon it and rupture the perclose suture, knowing that this has a risk of lacerating the artery and theoretically the patient requiring surgery. So the other option would be to take the patient to surgery and remove the perclose suture, which has been done before. We decided to try and balloon it with surgery on standby just in case we really lacerate the artery. We didn't we didn't want to cover this with a stent or anything like that. So I started with the small balloons just from the fear of that complication. But to be honest with you, the only balloon that would rupture a perclose suture, because it is a very elastic, it's not very elastic, but it's nylon, so it can expand, it can accommodate the pressure before it ruptures completely, was a 5/0 balloon. So this is a 5/0 by 20, and you could see there was a very big waist on the balloon, and all of a sudden, the suture ruptures and the waist opens. Luckily enough, didn't lacerate the artery or cause maybe a small dissection here at the site, but in general, we had good results, restored flow to the vessel, and we had manual pressure on the other side. So, but this is just one access site complication. I have one more access site complication, but then we'll go to...
Mazen, this is a great, just one question and one comment for others, that this vessel had great outflow into the profunda and into the SFA, so wiring was, I think, a reasonable option, in the absence of which, would you not suggest people, if this happens, if there is bad disease downstream, to approach surgery, because this is a pretty critical area? Or what are your thoughts on this?
I totally agree with you. It's interesting because surgery is not difficult. I had another perclose complication not long ago. One of my CTO cases actually, when we finished, we perclosed her groin with 2 percloses on each side is what I usually do. And the one on the left side was a little bit painful actually more than usual during the perclose device. We removed the perclose, hemostasis was good, pulses were good. When she was trying to sit up a couple of hours later, she couldn't. She had a lot of inner thigh and groin pain every time she tries to sit up. And I thought, okay, maybe this is something, will go away with time. Gave her some medicines. Came back and checked on her the second morning. She was peeing standing all night long. She couldn't sit down. And I just went, and there's one case report where the perclose can capture a small filament of the nerve that supplies the skin on the groin area and in the inner thigh area. And this patient actually, I called my vascular surgeon, decided to send her to surgery, told him exactly where the access site was, and I felt the suture needs to be removed. And he went in, very, very small incision, removed the suture, and the patient sat immediately after the surgery. And there was no way it would have done better if we had not removed the suture. So the surgery, I agree with you, is very easy. Takes minutes, really, just a small incision in that area. And the perclose suture is blue in color. They can identify it very quickly and cut it and remove it.
Good point, Owen. Mazen, move to the second then. Thank you.
There was a question about cutting balloon. I would be a little bit anxious about using the cutting balloon. The perclose is probably outside the artery, and it's like, capturing from the outside. I'm not sure if a cutting balloon from the inside it would help. I don't know. I would be a little bit hesitant, but I'm not sure. Second case, 65-year-old male, hypertension, hyperlipidemic, CVA, and smoker. Symptomatic left lower extremity claudications. Failed first attempt to revascularize the SFA, so we brought him back and we did a popliteal approach for the second attempt. He had very painful swollen left calf and foot a couple of days after the procedure. The revascularization parts went very well. This is a picture when we brought him back for the, this is the picture of the stent after it was done through the popliteal approach. So good results. And I just want to pause it here so you can see where the access site is. So the access site is right here, also diseased artery, but a little bit higher than you usually like it to be. You usually like it to be a little bit lower if possible. And this creates a problem. This creates a problem because it's harder to hold pressure at this site rather than if you hold it a little bit lower. And sure enough, all these, we take them in the cath lab and hold pressure while the patient is still in the cath lab on his belly before we send them out of the cath lab. So here you can see selective picture going up and over from the other side. And developed a pretty significant pseudoaneurysm that was not, possible to treat it by thrombin injection. You can see the patient has a very large neck. You can see the in and out, the contrast going in and out here, the washouts from the artery because of the blood inside the aneurysm, very wide neck, so no way to treat with thrombin. Now, I'm telling you, there are some reports there, and I've seen it and I've tried it, where people go in with a balloon, inflate a balloon here, and inject the thrombin. So we've done that more than once, and the success rate is not as high because they recanalize and they reopen again. If you scan them again the next day, because the neck is so wide, even if you keep the balloon up for some time until the thrombin has no more risk of coming back into the artery, this recanalize because there's a big surface area exposed to the artery and the pulsatile blood flow. So this was very simple. After we knew exactly where this was, there was a stent all the way to here. We extended the stent with a Viabon all the way down and excluded this this pseudoaneurysm, and the results were pretty good, and the patient did well. But his leg was, multicolor for a couple of weeks before it completely resolved, because this is pretty painful and bad. But this is just a quick 2 access site complications that you can see in peripheral arteries. The third case is a 54-year-old male, coronary artery disease, diabetes, hypertension, hyperlipidemia, smoker, had subacute left carotid stroke, left cortical stroke, and he had 89 to 90% stenosis of the left internal carotid artery by Doppler. So our neurology team felt that this guy needs to have kind of intervention on his carotid early rather than late, and I was talked into it, and I learned a lot from it. So this is a good case for people who do carotid arteries. So this is the lesion that was the culprit. You can see the lesion is a little bit not the usual typical lesion that you see at the bulb. It was above the bulb, and it just didn't look like a calcified lesion on regular cine, and you can see it here actually. So this is the lesion. We didn't see any mobile thrombus or anything like that. It was not staining, so we thought, okay, maybe we can stent this. So the usual thing, I put a 6 French destination or a Cook sheath, shuttle sheath all the way down in the common carotid. Filter, you can see it up here. This is probably one of our NAV6 filters. Pre-dilate, usually with a 3 or 3.5 balloon. Put a stent and then post-dilate with a 5 or maximum 5.5. Now, this picture to me was a problem even before I took the angiogram. I knew something was not right. And the reason I say that is because the stent expanded on its own. Usually in these tough lesions in the carotid, you really need to crack the lesion open, and the patient actually feels the pain in the neck before the stent takes a good configuration. Here, the stent already expanded bigger than the balloon, even before we inflated the balloon. And to me, this didn't sound very good because, you know, this lesion that was here was probably soft plaque or plus or minus thrombus on top of it in the setting of acute stroke. And sure enough, this next picture shows you what's going on. So here, there's absolutely no flow in that carotid. The patient was awake, but he was getting a little bit sleepy, actually, among no seizures, nothing like that. But you can see there's a whole column of blood here all the way up to the filter, which probably is now full of clots. The first thing you want to do is you don't want to remove the filter, because if you remove the filter, all this column of blood is going to go up to the brain and occlude everything. So the first thing we did here was we took one of the Pronto devices, and you can see here the Pronto, and we were suctioning everything in this column of blood that was standing still. Some operators would suggest putting another wire all the way and coiling it in the filter so that the Pronto actually, instead of stopping here at the site where the filter is, going all the way in and sucking as much as possible, even from inside the basket or as close as possible from the basket. The teaching point here is you need to keep doing this and empty the Pronto syringe until you see no more residual stuff coming out, whether it's clots, white, or whatever it is, coming out of this of the Pronto aspiration. Once you do that, you still don't want to inject anything because just in case there's stuff in the guide, you let the guide bleed back. You remove the filter the usual way you do, and then this is the picture after. We restored flow. Everything was good. Patient really did not have any sequelae. He went home the second day. But in retrospect, looking at this at this more closely, actually, this is the intracranial showing no embolization anywhere and no problems there. And this is just a close-up of the filter, and you can see here very clearly the cheese crater effect, where the thrombus and all the soft plaque extended from the stent struts. So this is a lesion that should not have been intervened on in retrospect because it was very fresh. Probably these are the patients that need to be anticoagulated and come back and be reassessed. But again, this can happen again in other situations when you have very tortuous carotids. And once you try to put the filter in this segment up here, one thing we've learned is that the filter itself can cause pseudo-straightening of all these lesions and can cause decreased flow in the carotid or no flow in the carotid. So the advice is to put, when you have something that tortuous, put an 014 wire, which has the same consistency as the filter wire all the way up. And if you see that this wire will cause severe tortuosity, kinking like this here, and no flow in the carotid, then you can just remove that wire and not proceed with your procedure. Here we decided to proceed. There was good flow. We never lost flow completely, but it did happen in another case. And we were able to successfully remove the filter and stent this lesion. But this is something I would recommend you consider if you are dealing with very, very tortuous carotids like this. So this is the only carotid case I'm going to show. But any comments, any remarks?
Go ahead, please. If there are any comments, this is fantastic cases. I think great learning opportunities. So any comments from anyone dialing in this morning? Mazen, I would suggest you proceed with the next case in the interest of time and then take questions at the end.
Okay, perfect. So 45-year-old male, severe left-sided claudications, previous left common iliac stent, refused vascular surgeries for revascularization, and came in for PTA stenting of the left common internal iliac artery. So he's very young. He's really a good surgical candidate, but he works in the oil fields, and he completely refused to get an aortofem bypass. Let me see here. This is sorry about that. This is the picture of what we're dealing with, the pigtail in the aorta. He's already had a previous stent here. The stent is completely occluded, and it occludes all the way and reconstitutes just a little bit here at the, you can see very quickly here, the reconstitution right here I'll take this out. So very long. This is definitely surgical disease. By no means this is necessarily a first-line treatment, endovascular, but the guy really insisted we do endovascular. My approach was there was a small nubbing up there, so we were able to very easily cross this lesion with a quick cross and regular wire, and this is just to confirm we are in the distal vessel without any problem. We cross it up and over, and we were able to get our 035 wire down, and this is after ballooning with a 5.0 balloon. You can see there's no internal iliac, nothing. There's just good blood flow now. So we just wanted to stent and expand the stent. So we put stents down here. We put the self-expanding stents, and up there we put another balloon expandable stents. And this was probably in retrospect a little bit bigger balloon than what we needed, because you can see after we post-dilated we had a big perforation here. So I've seen this twice, once as a fellow and once as an attending, and these patients, you can see the blood pressure on the monitor go down from 140 to 60 in literally 3 heartbeats. It's amazing how quickly their heart rate goes down, blood pressure goes down. The good thing about all this is that we did have a good wire down all the way, and this area was already stented, so we were able to balloon tamponade it until we get covered stents. So this is a balloon tamponading from above, and you can see we injected and there was no problems there. Now, you might have more problems if that internal iliac was not completely occluded and was getting collaterals from the other side, because then even though you might be able to completely occlude this segment, once you put a covered stent, you just need to make sure the collaterals that are coming to the internal iliac are not causing an endoleak around the covered stent, and the patient continues to bleed. So this is something to think about if you have on the other side collaterals through the internal iliac arteries. Anyway, this is after some long balloon angioplasty and covered stent that needed to be post-expanded, because you can see dye coming here around the covered stent and still leaking out. So we post-expanded these, post-dilated these with bigger balloons, I think an 8.0 balloon. Finally got very good, decent results, and they guided well, but of course lost some blood. So this is another bleeding not related to access site complications.
Then I have a question. Did this perforation happen through the stent, if I'm mistaken, or this was an unstented segment that you were pre-dilating?
No, this was a stented segment. I think I was a little bit too aggressive with the post-dilatation.
I think this and if our fellows are joined in, why?
So the thing I learned from this, whenever I have iliac arteries, I know there's a lot of stents that go through 5 French and a lot of push to do smaller sheaths. Iliac arteries, I never use less than 7 French, just because I've seen this twice in the 8 years I've been either an interventional cardiology fellow or attending, and twice. I mean, you need to react very quickly. There's no time to upsize sheath and put a better wire, and you cannot be working with this over an 014, 018 wire. So my approach to iliac stenting is to use 7 French sheath, and 035, I usually use a Rosen wire, which is a stiff wire, to be able to deliver a covered stent and stuff if something like that happens. Now, this is not going to happen very frequently, and when it usually happens, the perforation is almost always at the bifurcation of the common iliac to the external iliac. Seems like this transition from the common iliac to the external iliac, there's a weak, the artery wall becomes weaker because it gets smaller, probably less muscle. And if there's a lot of disease there that you're just pushing out, you can perforate. I mean, at least in these 2 cases, these were where the location of the perforation was.
Great teaching points, Mazen. Great teaching. Do you have another case?
Yes. Do you want me? I'll go until you tell me to stop.
No, we can just do one last case and then we can do some questions.
Okay. Well, this case will be very quick, and it's a 67-year-old male with coronary artery disease, diabetes, hypertension, hyperlipidemia, PAD with 2 stents in the SFA outside facility 2 years earlier. He has lifestyle limiting claudications. We got him to the cath lab, and this is the SFA. We got access from the other side, from the left side. This is the right, and you can see the SFA is occluded here, just at and it reconstitutes through profunda collaterals, so the knee joint is somewhere here, so it constitutes almost mid to distal SFA. Now, interestingly enough, when you look at these stents, we noted that these stents were Viabahn stents. And the occlusion was all the way from the ostium of the Viabahn all the way down to here. Now, the only thing I will tell you is that it was very difficult to go through the proximal and the distal cap, but inside the stent, the wire acted as if it was empty. There was nothing inside, you know. I mean, of course, there's something inside, but there was no resistance, nothing. The wire flew all the way down to just the distal cap, and it was very hard to get through the distal cap. If we were in the true lumen, everything went well. We decided to use the pathway device. And the reason why I used the pathway device for specifically is because I wanted something to aspirate all the junk that was sitting inside the stent, because this stent has been there for a long time. And it was, I mean, the way the wire flew through there, I knew there was, just clot there, or probably just old blood sitting there clotted. So I spent a lot of time at the distal cap, probably not long enough, to try and aspirate as much as we can. And after that, we had good results. This is just after, we stented. So we had to put a very short 20 millimeter stent here, because this would, we didn't do anything inside the stent, not even a balloon. And look how clean it is inside the Viabahn. And distally, we had to put a very short stent because this was very tough here. But everything looked good. We were happy with the results. And we were taking last pictures, at the foot to see what was going on. The guy started complaining of foot pain. And now you can see there were some issues. You can see that now there are issues with the distal circulation. So the guy had 3 vessel runoff, and you can see here the vessels coming in very late. But we trashed his foot. Everything is completely occluded. So whatever was in the stent, even though we used aspiration as much as possible, it wasn't big enough. And you could look clinically at his leg, and you can see his leg was completely pale, cold. He was starting getting some numbness. So the only thing I did is I put an infusion catheter all the way down to here, and we infused TPA at a rate of 1 milligram per hour, and we diluted 60 cc's per hour for 6 hours, and then at 0.5 milligram per hour until the next morning, and completely resolved, had good DP, PT pulses, and clinically everything went well. But this is interesting because we are always kind of, can see these Viabahn cases now being used more. I have nothing against Viabahn, but I'm saying probably when you open it and open the distal cap, you're always going to shower things distally. So I don't know if it was better to use NGJet inside. Some people have used Trellis to try and suck out everything, but this is a good, interesting, case and, complications. So I had one more case, but we can stop, and I'll be happy to, start a discussion.
I think it's fantastic, Mazen. Thank you I think we should stop here and take some questions. My only comment was that, for total occlusions, I don't know whether our fellows are joined in or not. We routinely in the pelvis, in the iliac, do use intravascular ultrasound to decide if we are in the true lumen or not. But I think it has been our strategy. However, I think there are multiple ways of doing it, and you have shown some outstanding cases and some great teaching points. So I open it up quickly to all the members joined in. I thank them for joining in on the XLPAD webcast. And please ask away your questions to Dr. Mazen, if there are any.
Mazen, this is Drew Klein from St. Louis. How are you doing? Those are great cases, and I just want to hammer home, especially for any fellows that are there, I always routinely for the iliacs use 7 French because of that exact same reason. You only have to see that once, and then usually for the fellows, it's usually always on post-dilatation that rupture occurs, and I usually will leave the balloon on the wire or just inflate, and usually the patient has some sort of pain to let you know, and I watch the blood pressure, and once that starts falling, I don't even need the angiogram to tell you exactly what's going on. So that was a great case. And then for the Viabahn, we've seen a fair number of these. So we have some providers out in the community that do that. I think it's a great use of the Jetstream device. The only issue is that you can't obviously use embolic protection. You can use a NAV6, but the spider filters have a tendency to get stuck on the device gets stuck on the wire. So I've been using the AngioJet for those, and then for this distal embolization, they have a Salant distal, which goes down to 1.5 millimeter vessels, which we found useful for anything that gets thrown down below, just because I don't feel like waiting 6 hours for TPA, and getting our nurses
but
to handle
the interesting thing, there was not one thing. I mean, I went down all the way to the big toe, to be honest with you, with wires and catheters, but there was not one thing to aspirate and take out. I think it was very, very fine material.
Fine material. No reflow, essentially, of the leg.
No reflow, exactly. I mean, I wish we
just had that
to
yesterday,
show you the next case was a great case of reflow. And there was absolutely, I mean, I'm just going to go very quickly actually to this. I want to show you this no reflow. And this is essentially what happened to this guy. And there's another guy we had to do here. So just look, this is a catheter injecting down, and you can see there's nothing. I mean, the guy is backfilling. There's no big clots anywhere, but there's just absolutely no reflow in the leg. So
I had this exact case yesterday, actually, and that's I wound up putting a catheter distal and just trying to drop a bunch of nipride, adenosine, and everything else to try to improve it. Eventually, resolve with time. But I've definitely seen this. It's a real challenge to deal with.
Have you ever used any embolic extraction devices here, or maybe they are too small? But those are very good points, Andrew and Mazen. I think it will be very valuable to learn from your expertise from these cases. And
I used aspiration yesterday on this same thing. I used multiple devices, including a larger ASAP device inside the tibials. I use the aspiration for that as well, just because obviously you're not going to be able to deliver, just like in a vein graft that has no reflow, you have to remove the static column of crud. And so with that principle in mind in the leg, I basically would aspirate from, like I said, I just did it yesterday, from the posterior tibial from the top to the bottom, anterior tibial from the top to bottom, same thing with the perineal, and then went back through and then delivered drugs distally, kind of similar to what we would all do for vein graft. And it seemed to improve the situation. I think the other approach would be to do what Mazen did, which was great, which is to essentially drop an infusion catheter down there, and just time will help it all out.
I agree.
Yeah, I mean, I gave a lot of nicardipine, adenosine, all this for both these cases, the second one especially. And the second one was very interesting. Nothing worked. I mean, the second one, he had symptoms from his knee down because, as you can see, even his trifurcation vessels had no reflow. And this was just a native SFA, the second one that we ballooned, and it happened after the balloon. And I was going to ask Dr. Banji, what happened with these balloons that, they can suck the stuff out? I never saw them again.
It's still available. It's limited. It's still available. However, there's an excellent discussion on how to manage distal embolization. Any other questions for any of the other cases? Because I don't do many carotids. I think there are people who do carotids, and I think this will be an excellent opportunity to ask Dr. Mazen something about carotid complications.
There was some questions coming online, but
please do go ahead. Answer the questions online.
I do not see them. I was trying to look for them because I saw that some were coming, but I don't see them.
Look at the question. There was one question from Dr. Robert Dieter. Would you consider using a filter wire in the popliteal before intervening? So the question would be that if you cannot protect and you do not have a way of doing distal embolic protection, would it in any way alter your treatment strategy for these via-bound occlusions? I'm trying to paraphrase Dr. Robert Dieter's question.
So I think what the issue was kind of touched upon. The only filter you can use if you want to use the jet stream would be the NAP6 filter, because it won't get caught. If you're using NG-Jet or others, you absolutely can. I think in retrospect with these via-bonds, now that we're seeing more, I mean, there's always stuff inside them when they're completely occluded. I think we should consider using stuff.
That the question from Dr. Robert Dieter is very good and I think very specific. I just want to reiterate that if should the embolic protection strategy drive your treatment strategy rather than vice versa? This is an open-ended question, but I think worthy of discussion. So your comments, please.
I think in retrospect, absolutely. I think when you find a patient, I mean, sometimes, we say if you have more than one vessel runoff, you really don't need to put a filter and stuff. But the strategy here would not necessarily change for me because I knew I wanted to do something to suck all the thrombus from inside the via-bond. I think the filter would have been an added protection point. Using the filter alone, I think, would overwhelm the filter, and you essentially need to do something again to try and remove all the thrombus. I think the strategy was to do aspiration, but I think additional filter would have helped because the we could have decreased the amount, but you can never make it zero, I guess, and hopefully the filter would capture the others.
Excellent point. Any other questions from any other attendees before we close this morning? Any other questions? I appreciate all of you joining on this XLPAD webcast given by Dr. Abu-Fadel Mazen. I want to thank him for his time and each one of you for participating and joining in this morning. Thank you all. Thank you very much.
Thank you.
Thank you.